All right. Again, the State Epidemiological Outcomes Work Group is funded by the Delaware Department of Health and Social Services, Division of Substance Abuse and Mental Health, through funding and support by SAMHSA. Today, we'll continue to, as folks are coming in, welcome, introduce yourselves in the chat. If you have time, we will review the SEOW goals. We'll highlight some new data products that are available. We'll have our main presentation today, which is Dr. James Ellison, which is, we're really blessed to have him come and talk to us today about a really important topic. We hope that you'll take a lot away from this particular presentation. And then at the end, as we always do for folks who are new, if you have events coming up, this is a great space to share that in. If you have calendar items, just things you want to share, resources, feel free to drop them in the chat, or we can share them at the end. We do send out slides and minutes. We do post things on our website. So we give us about 2 weeks to have everything up. We will send out minutes and all kinds of things. So if there's a resource here that you want to make sure you grab, we will have our email addresses in the chat, but feel free to reach out directly and we'll make sure you get what you need. Shauna?
So the goals of the SEOW are 4 main goals here: to build monitoring and surveillance systems to identify, analyze, and profile data from state and local sources, to identify, share, and analyze this data, to create data-guided products that inform prevention planning and policies, as well as to train agencies and communities in understanding, using, and presenting data effectively.
Thank you, ma'am. To that end, if you joined us in January, thank you. It's good to see you again. Each year we put together a epidemiological profile for the state related to behavioral health and other contributing factors, things like gambling, protective factors, maternal behavioral health, and all of those items are now available on our website. We did do a webinar on these items just to orient you. We've streamlined the process. Shout out to Sharon and our colleague Rachel Writing, who isn't here today, but they did a great job just really refining and honing in on the items that are so important to people. So our website is available. Shauna will drop that in the chat for you, but the slides are available. If it's on our website, it's for you to use. So please do. If you have a presentation coming up and you want to talk about a particular topic, the slides are available. No permission is needed if they're on the website. Our review of the webinar is on YouTube, and it's also available on our website. We compiled an executive summary of the entire profile that's also available on our website. These are live links, and they'll also be in the chat if you want to grab them. We have a cannabis short report that we're getting ready to put on our website in the next couple of weeks, and we have an updated infographic. We were really excited to put together the report for cannabis legalization and public health. We really took this from a balanced perspective, about what are the lessons learned, what are the challenges around legalization. As a reminder, this is a data-focused work group, so we don't take a stance one way or the other, but we do talk about the challenges. Also from a research perspective, when things are not legalized or there are restrictions on researching any particular product or those types of things, what challenges that means for us, what are the quality concerns around THC, cannabis, all of those other things. So it's an interesting report that'll be published, put on the website in the next couple of weeks. We also, a couple of years ago, did an older adults and behavioral health infographic, really highlighting the importance of considering this population in behavioral health efforts. We updated that this past week or past couple of weeks with new data, and that should be available on our website again in the next couple of weeks, and we'll send that out. We wanted to highlight this topic, and for our prevention providers, you may be wondering, well, why are we talking about our older adults, our seniors, our elders? Because I think folks believe that prevention is a young people's kind of area. And for the most part, it is, right? But we can't forget our seniors, we can't forget our elders, because this is a population, number one, that is so critical to the stability of our country and our stories and our cultures and our values. And so that can't be forgotten. And number two, as our population is aging, you get folks like myself and others who are in between seniors that they may be caring for, or older adults that they may be caring for, and also teenagers at home. And so we're kind of in between. And so that's important for us to understand what are the needs of our older adults. And then finally, because you know, we do have our grandparents raising grandchildren. And so for our folks in that prevention space, we want to highlight how important it is to consider the needs, the unique needs, the specific needs of our older adults and seniors. And you're going to hear that word used interchangeably: elders, older adults, seniors. Specifically on our infographic, when we're talking about 65 and older, we mention 65 and older. When we're talking about 50 and older, we're talking about 50 and older. And sometimes that's related to how the data set grabs it. And that's how we've communicated it thus far. The other thing that's not on here, just kind of as an aside, if you are a primary prevention provider in the state of Delaware, you should have received a survey from us on the SEOW team. If you have not received that, please put your email in the chat, and myself and my colleague, Emily Rell, will make sure you get that survey. If you've already received it and completed it, thank you very much. The state is looking to understand a little bit more about the primary prevention landscape in the state of Delaware. And so we did send out a survey. If you didn't get it and that applies to you, please let me know. If it doesn't, that's fine too. All right, Sharon's gonna start us off or finish us off here.
Thank you, MJ. And as you've mentioned, we have a topic today that is very important, and it's personally very near and dear to my heart and professionally. I think we often overlook older individuals when we're talking about behavioral health, and at times we tend to think that behavioral health issues that might develop for older individuals are part of the normal aging process. So it's very exciting to us to be able to welcome Dr. James Ellison as our featured speaker today. He serves as a professor of psychiatry and human behavior at the Sidney Kimmel Medical College, where he also directs the Farber Center's Comprehensive Alzheimer's Disease Center, and he sees patients in Jefferson's outpatient psychiatry clinic. In addition, through Jefferson's neuroscience agreement with BB Healthcare, Dr. Ellison consults to BB's psychiatry department. Previously, he served at Christiana Care's first Swank Foundation Endowed Chair in Memory Care and Geriatrics, and also as director of the Swank Center for Memory Care and Geriatric Consultation. Before he came to Delaware, he directed geriatric psychiatry programs at McLean Hospital, which is Harvard University's principal psychiatric institution. He attended college and later trained to be a psychiatrist at the Massachusetts General Hospital and spent several decades working as a general and geriatric psychiatrist. He also received a Master's of Public Health degree from the Harvard School of Public Health. His clinical specialties include the assessment and treatment of neurocognitive disorders in older adults and the evaluation and treatment of resistant mood disorders in later life. His research interests have addressed cognitive and behavioral aspects of the neurocognitive disorders. And in addition to teaching, he has served as a site principal investigator in multiple clinical trials, authored more than 70 peer-reviewed publications, and edited the Journal of Geriatric Psychiatry and Neurology. So we have here someone with a wealth of experience and knowledge about these topics, and these roles demonstrate his lifelong commitment to the behavioral health care of older adults. He served in very diverse settings, including emergency psychiatry clinics, inpatient and outpatient settings, managed care, and private practice. So we're very grateful to welcome Dr. Ellison here, and thank you for the upcoming presentation and your time today.
Well, thank you for that nice introduction. I'm going to see if I can share my screen here, which I hope I can. It looks like. Are you looking at my screen?
Yes.
Great. All right. Well, thanks so much for inviting me to talk to your group. Obviously, we have a lot of shared interests here, and I was so glad to hear about the work you've already done on behavioral health care needs of older adults in Delaware. Delaware is doing a number of interesting things for its older population, which is great because, as you'll hear, Delaware is a state that has an older population than many other of the United States. What I want to focus on here is not so much the nuts and bolts of clinical treatment, but the epidemiology and the behavioral trends and some of the new advantages and challenges that face us at this point. So I'm going to move on to this next slide here, which shows that in the United States overall, seniors are a growing percentage of the population. If we take a look at the year 2000, there were 12.4% of the population was 65 and older. And it's estimated that by the year 2050, that will grow to 22%, a big increase in this section of the population. Right now, the United States is around 16% elders, and Delaware is higher than that at more than 20% elders. If we look at the population pyramid of the United States, what we see is the baby boomer bulge and the baby boomer echo bulge, which shows that we're in the running for a number of years of older adults. The youngest baby boomers turned 60 this year, which means that now they're going to age into the older age group over the next 10, 15 years. And if we take a look at Delaware, those bumps seem to be somewhat exaggerated. There are, Delaware is known as a retirement destination state, and Delaware is the 5th oldest ranked state of the United States in terms of its population. More specifically, or in more detail, 20.8% of Delawareans are 65 or older as of last year's statistics. And we can look at this another way and say that the median Delaware age is 41.4, which is several years older than the median age for the United States overall. Now, Delaware is a funny kind of a state in that it has 3 different counties that are quite different from each other. In Newcastle County, the older population is closer to 16% and is somewhat stable. But in Sussex County, where a lot of retirees head for the new developments in senior living, that's where the highest concentration of elders is in Delaware, 24.4% of the population, and that's slated to increase. The larger increase in 75 and older is projected for Sussex County and Kent County. Newcastle County's older adult population, again, is relatively stable for now. Now, if we take a look at general health characteristics of the Delaware population overall, Delaware ranks number 18 in the healthcare quality state list. There are a number of characteristics that help us understand about Delaware's situation. Delaware has a high rate of poverty and a high rate of income equality. This leads to very high healthcare disparity, also because of the diversity of the population. If we take a look at the healthcare rankings, which have been improving, still Delaware is pretty low, ranking 36 out of 50 in the number of uninsured, 39 out of 50 in hypertension prevalence, high cholesterol, diabetes, obesity, and chronic kidney disease, all very high in Delaware's mixed population. Many of these are conditions that affect the elderly group. If we take a look at Delaware's seniors in particular, we see that drug deaths are kind of in the middle of the range of the United States, but access to care is in the lower number of states. If we take a look at things like physical inactivity, Delaware's seniors rank low in physical inactivity. Obesity, which goes along with that, sleep deprivation, excessive alcohol use, which we'll talk more about, and very, very low in multiple chronic medical diseases, 48 out of 50. On the brighter side, among states, Delaware ranks with lower reported rates of late life suicide or cognitive impairment. I'm not sure what that reflects. I have a sneaking suspicion, it may reflect poor detection rather than poor low rate. Delaware's state and our elders face mental health challenges, and I wanted to focus on 4 Ds here: dementia, which is prevalent and increasing in number; depression and suicide risk, which are prevalent, somewhat stable in number, but very treatable. That's what we can call low-hanging fruit in the treatment world; drug concerns, which are growing in the elders and significant, especially alcohol; and then how diversity impacts each of these conditions. These are all conditions which we can expect to affect the senior health in our state in increasingly over coming years. So let's first talk about dementia. There's been a lot of memory discussion in the news lately as a result of the press conference that our president gave and various other older public figures. So we've been thinking a lot about what is typical normal aging, which can involve slowing down of processing speed, and it can involve forgetfulness. Some people even have subjective memory impairment. Some people feel that their memory is not working well, even though objective testing doesn't demonstrate that. Then there's the group of people, which is significant and of importance as a result of new treatment development, that have what's called mild cognitive impairment or mild neurocognitive disorder, who have a demonstrable lowering on neurocognitive testing and need to engage in compensatory or workaround behaviors in order to function at the level that's necessary. And then finally, when cognitive changes that are acquired during adulthood become severe enough to interfere with independence, we call that dementia. And dementia is a significant problem everywhere in the world, but in Delaware, we see it as a growing problem, which I'll talk about. Dementia is defined as a condition in which there's evidence of significant cognitive decline. It's acquired in one or more domains, usually memory, but it could also be visual spatial awareness, language, complex attention, even social cognition, executive function. It interferes with independence in everyday activities, and it's not delirium or another mental disorder such as depression. Now, we've known about Alzheimer's disease for 100 years as a result of Dr. Alzheimer, whose picture is here. At this point, over 6 million United States adults live with dementia, and Alzheimer's disease is considered the most prevalent neurodegenerative dementia, accounting for 60 to 80% of cases in the United States. The biggest risk factor is age, so that 73% of people with Alzheimer's dementia are 75 years or older. And the prevalence is still growing because this year, the oldest baby boomers are turning 78, and the growth of prevalence of Alzheimer's disease is increasing through the 70s and 80s. Now, along with the people who suffer from dementia are the caregivers. And in the United States, the number of caregivers is estimated at 11 million, resulting in a very high cost to our healthcare system, even if we don't include the unpaid caregiving that these caregivers provide. I'll just briefly mention that although Alzheimer's is the most common cause of dementia, there are lots of other causes, and that's one of the reasons why these diagnostic evaluations that people go through are so important. Let me focus now on Delaware, where an estimated 19,000 people had Alzheimer's dementia in 2020, and a projected 23,000 will have it in 2025. Delaware's caregivers number 31,000, providing 45 million hours of unpaid care per year at a cost of $85 million per year. And many of these caregivers are at high risk for medical complications or depression. Almost 2/3 live with a chronic medical condition, and almost a quarter live with depression. It's a high-risk situation. The majority of Alzheimer's disease, the mortality of Alzheimer's disease and dementia is very high. It's the 5th most frequent cause of death among older Delawareans, if we look at 2017 to 2021 figures. Of course, during the pandemic, COVID became the most common cause for mortality during the elders. And in 2021, only COVID caused more deaths in the 75 and greater age-old population. Only COVID caused more deaths than Alzheimer's. So a lot of focus is now turning on mild cognitive impairment and Alzheimer's disease as a result of new treatments that are disease modifying. And hand in hand with those new disease modifying treatments, we're seeing new diagnostic tests that promote early diagnosis. Also, as people with Alzheimer's are surviving longer, thanks to improvements in medical care and understanding and facilities that treat these patients, we're dealing more and more with the burden of non-cognitive or behavioral treatments. And we're also learning more about prevention. I'm going to just say a little about each of these urgent issues that are coming up with mild cognitive impairment and dementia now. We know now that Alzheimer's disease is developing in the brain silently, perhaps for decades before it causes any symptoms. And when it first causes symptoms, they're mild, as in mild cognitive impairment. We have identified biomarkers, both neuropsychological tests, which can be digital or administered on paper and pencil, neuroimaging tests like functional and structural imaging modifications, cerebrospinal fluid measures of metabolites and biomarkers, and blood tests of metabolites and biomarkers that help us identify, even at an asymptomatic stage, who is at high risk to develop Alzheimer's dementia. That's good because, as I said, it goes hand in hand with the development of the first effective disease-modifying medications for Alzheimer's, which are called monoclonal antibodies. And you've heard about aducanumab and lecanemab, and then on the way soon we may hear about donanemab and others. Now, the non-cognitive symptoms, to my mind, are equally important or more important than the cognitive symptoms because many people can be managed with memory difficulties with relative ease and success compared to the burden on caregivers that's provided by non-cognitive or behavioral symptoms. And we can even look to Alzheimer's first patient, Auguste D., the woman whom the first patient with this condition, whom he evaluated around the beginning of the 1900s. And she was hospitalized in Frankfurt, Germany, because of her difficulty with behavior, screaming, agitation, hallucinations, delusions. We know now that the changes in behavior include mood changes, which can be depression to the point of suicidal behavior, mania, thought disorders with delusions, hallucinations, and activity changes with agitation, wandering, inappropriate or aggressive behavior, and sleep and eating disturbances. There are approaches to these which require some expertise. Many clinicians who are faced with the treatment of these disorders need to sort of update their knowledge of what's new in this area, but there are some new approaches that are working better. On the topic of prevention, the World Health Organization has been very helpful in cataloging information and determining the population attributable risk of various factors, such as low education, hearing loss, which is now considered the biggest preventable risk factor for the development of dementia, brain injury, high blood pressure, alcohol use greater than 3 drinks per day, or 21 units per week, obesity, smoking, which is still popular among the elders, depression, which contributes a significant risk, and loneliness, inactivity, air pollution, and diabetes. These are remediable factors that can be addressed in our patients' lives. Now, in Delaware, the challenges that I see are, first of all, educating the public about what is a preventive brain healthy lifestyle, including hearing tests and hearing aids for correction of hearing loss, eyeglasses for correction of visual acuity loss, other preventive interventions like diet and activity, and social activity and cognitive engagement and so on. And then chronic medical disease management, diabetes, hypertension, obesity, sedentary lifestyle, these things that are high in Delaware. The treatment population, the treatment provider population needs to be educated and updated about the new diagnostic tests, what's good about them, what's not so good about them, such as the direct-to-consumer marketing of blood tests to measure your amyloid level, which probably is more problematic than getting a evaluation from a primary care or specialist clinician. And then the memory clinic, which is sort of the gold standard evaluation. And in Delaware, that's the Swank Center in Wilmington, part of Christiana Care. The definitive evaluation can be done by any skilled provider, but typically a cognitive neurologist or a geriatric psychiatrist is the most educated about this. In Delaware, we only have 13 geriatricians, another group of clinicians who are excellent at evaluating dementia. And we have very few geriatric psychiatrists and very few geriatric or cognitive neurologists. There are also limited facilities to treat people, especially with the behavioral issues that come with dementia. So access to treatment, both individualized treatment and the newer types of treatment, is just not widespread in Delaware. I would mention that the University of Delaware has taken great steps in their Center for the Delaware Center for Cognitive Aging Research, which is associated with a wonderful program for education of the public about risk factors, and a registry for mild cognitive impairment, which is feeding into their research programs, looking at things such as exercise and its effects on cognition and nutritional supplements. The Swank Center is the gold standard in Delaware for diagnostic evaluation. And caregiver support, there are many programs through DSAPED, and I'll mention this. However, as I tried to follow up some of their links, a number of them were great, but too many of them led to programs which went defunct during the pandemic or no longer are active. And so I think that the DSAPED programs sound great, and many of them are active, but some of them need to be updated. Now, depression is a big factor in later life as well, although much less common, about less than half as common as dementia. When we diagnose depression in later life, we use the criteria developed for younger adults: depressed mood or loss of pleasure, and then at least 4 of weight loss, sleep disturbance, motoric, psychomotor activity disturbance, change in energy, worthlessness or guilt, diminished concentration, thoughts of death or suicide. In the elderly, these criteria are a little bit more confusing because a lot of older adults have other reasons for changes in appetite, sleep, activity, energy, and sense of worth. So it's a little bit confusing to use these criteria. There are other diagnostic schema like the geriatric depression scale or even the PHQ-9 that clinicians use to screen. And ultimately, a more thorough evaluation once a person screens positive is important. The prevalence in the general population of significant depressive symptoms is 8 to 15% among the elders, but only 1 to 3% for major depressive disorder. As people get older, 75 plus, the rate goes up as high as 10.6% for the 75 plus population. And in primary care, we see a higher rate among the elders, and especially in long-term care, up to 25% of people can have major depressive disorder, and up to 50% can have significant depressive symptoms. So those are very important areas for there to be good services for diagnosis and treatment. When people are not treated for late life depression, they use twice as many medical appointments and take twice as many drugs. They don't take care of themselves as well. and follow up with treatment of things like high blood pressure and diabetes, they decline functionally and physically with greater disability, and they have increased problems related to many disorders. And I'll talk more about suicide in a moment. They cost more to the healthcare system. And yet, if you can imagine this, half of people with depression in later life go untreated. And many of those who are treated suboptimally. There's a lot that can be done to upgrade our expertise in treatment of late life depression. Now, a very important thing about late life depression, which differentiates it from earlier life depression, is that many of these people have medical burden that's relevant, like cerebrovascular disease or cardiovascular coronary artery disease or other kinds of vascular disease, or inflammatory diseases, or cancers, or neurological diseases, or depression can be the prodrome to a neurodegenerative disorder and so on. Or this can be the result of interacting medications. So the medical burden of the older population requires a more careful evaluation of depressive symptoms. And older adults tend to want that to take place in primary care. So collaborative care or integrated care, where a behavioral health person is embedded in primary care, which has been a popular approach in Delaware, is a very good way of picking up these people and helping them come to medical attention and get treatment. So this is about the medical burden. Effective treatment requires attention to the medical disorders and the adverse effects of medical treatments and drug-drug interactions. So special expertise required. Now, depression in later life is usually a consequence of inadequately treated depression. Depression is the most frequent antecedent. In younger life, substance abuse is a much more important factor. In older life, depression. And suicide rate increases with age. You can see that among the 85 and older group, 55.7 people per 100,000. That's about almost 5 times the general population rate for the United States. Very high rate. You can see it's much less among women. And among men as well, a very interesting thing. Over 80% of these suicides in older men involve firearms. So it should make us look at gun ownership and licensing policies, I think. Other ways are much less frequent: poisoning, suffocation, and other mechanisms among men, a little more common among women. In older adults, because of the firearms popularity, 1 in 4 suicide attempts is fatal. So we have to take any kind of suicidal ideation or threat in an older adult, especially an older white male, very, very seriously. Other risk factors are if they're a widower, living alone, isolated, poor social support, financial stress, medical stress, functional stress or disability, a bereavement or other event, and access to firearms or other lethal means. But again, depression is the most important thing to pick up. And in a 2004 study, I think things have probably gotten a little better. And in Delaware, in many hospitals, suicide risk screening is part of admission process for medical disorders, which is great. But in a 2004 study of United States depressed elders seen in primary care during 12 months preceding a suicide attempt, less than 1 in 10 had received the appropriate depression diagnosis. Now, this looks a little bit hopeful, as though the risk for suicide is kind of stable among different age groups and going down in the highest risk group. But if we look at the United States, for which we have data, it looks like that was a temporary dip that rose again during the pandemic, and that suicide is again on the rise. In Delaware, I mentioned integrated or collaborative treatment. That's been shown in studies like the famous PRISM study, that integrated care reduces suicidal ideation and risk. And screening for depression and suicidal ideation is increasing in Delaware, thanks to good work that's being done in that area. And access to behavioral health care for late life depression, however, remains limited. specialists, psychiatrists, geriatric psychiatrists, primary care expertise in late life depression treatment needs to grow in our state, and suicide prevention programs that address their specific issues. And then, as I mentioned, gun ownership policies, in my opinion, worth reviewing. Next, let's move on to drugs, illicit drugs and alcohol. And alcohol and drug use in the overall United States is pretty high. Alcohol, about 43% of older adults within the last year have used alcohol. Many have used tobacco. There's a lower rate of tobacco use in older adults, but unfortunately, I don't think that's because of quitting. I think that's because of dying and survivorship of people who are not smokers. Cannabis is growing. Opioids are small but growing. If we take a look at binge use and abuse of alcohol, what we see in the overall United States population, heavy alcohol use was 3.4%, but it was higher in Delaware at 4.6% in 2021, and overall high level of use of alcohol. Now, in later life, alcohol it packs a greater punch because of changes in the liver, kidney, brain, volume of distribution, which has to do with the amount of water and fat in the body. So that we say that appropriate limit for older adults is certainly no more than 2, and usually no more than an average of 1 standard drink per day for an older adult, 65 or older. No binge drinking 4 or more standard drinks in one day, and no drinking mixed with certain illnesses or medications, which is an issue. And for women, even less alcohol is appropriate. And yet, many older adults are drinking at that level. And many older adults, as I mentioned, are smoking. The rate between 2013 and 2021 remained pretty constant, between 8.7 and 9.1% in the United States in older adults. And some correlates in the general population of smoking are younger adults higher, because the older adults probably don't, they don't reach an older age. Men more than women, although that's been changing. Non-Hispanic white more than Hispanic, non-Hispanic black or Hispanic or Asian. Lower educational level, lower income, unmarried, disabled more than not disabled. And those with depression or psychological stress can resort to tobacco for relief. Moving on from tobacco, prescription drug use is a big issue among older adults. They consume the majority of prescribed and non-prescribed over-the-counter and prescribed pharmaceuticals. In older adults, we worry about pain meds and especially about hypnotic sleeping pills and anxiolytics. Insomnia and chronic pain are common reasons for people getting prescriptions, sometimes from multiple doctors who are not in communication with each other. Cancer, osteoporosis, or arthritis, and back pain, leg pain, or pain following surgeries are very common. This is just a demonstration that over 3/4 of the prescription drugs are used by elders, compared to much lower use in younger adults. Very common still among these drugs that are used by older adults are benzodiazepines, the use of which continues to increase, averaging 13.5% for those 65 and older, and growing even up to age 90 and beyond. And it's even growing, according to this study, between 2003 and 15. There was a doubling of primary care visits during which a benzodiazepine was prescribed, more among women than men, and interestingly, use is higher among individuals with dementia, where we know that this creates a cognitive problem and a greater fall risk. These drugs are rarely used illicitly in the sense of abused or addicted among elders. It's more medicinal use, which is misused in little ways, rarely taken for euphoric effect, and dose escalation is rare. But in older adults, these drugs are slower to get out of the body. They build up in the brain and cause balance problems, increased falls, interference with cognition. And if people are hospitalized or go on vacation or run out of prescriptions, their physician retires, they can go into withdrawal, and that can be quite serious. Now, moving on to opioid use, not a huge problem in the older adults in the United States, but a growing problem. About 15% of community dwelling United States adults over 50 received an opioid prescription in 2020, smaller number of over 65. Misuse of these prescriptions is about a third, and it's associated with depression, anxiety, PTSD, other behavioral issues, and substance abuse, and pain, of course. Women more than men. What we call problematic opioid use is use with untoward consequences, as opposed to use related to addiction, tolerance, and withdrawal. But problematic opioid use affects 2% of elders, and opioid use disorder or addiction affects less than 1%, you can see. However, I thought this was very interesting that in the United States overall, from 2000 to 2020, there was a very big increase in synthetic non-methadone opioids. And of course, you know that means fentanyl, which is an increasing problem, primarily fentanyl. These are opioid deaths. Now, these drugs alone have consequences, but they're often combined. And adults 65 and older, again, are the largest consumers of prescription and non-prescription drugs. Age-related changes in physiology make combinations of drugs potentially dangerous. But many older adults are at great risk for getting multiple prescriptions because they have more diseases, so they get more doctor visits, they get more prescriptions. Their care is fragmented among different specialists. They may go to the emergency room and get something prescribed there, pain medicine or a sedative, hypnotic, or a sleeping pill. One drug can be prescribed to counteract the adverse effect of another drug, which leads to a cascade of prescribing with side effects. And my experience is certainly that many older adults see multiple providers without getting their medicines reconciled. So not everybody who's treating them even knows what they're all taking. And the pharmacies can inadvertently feed into this by automatic refills or requests for prolonged duration of refills, like 90 days with 3 refills may be a default choice in some prescribing programs, leading to medications that have been discontinued still being dispensed. Some of the problems that occur are medical condition requires additional medication, but the old one isn't stopped. A patient taking an unnecessary drug, a drug that's been replaced by another one, for example. The wrong drug for the patient's condition, the too low a dose, which is very common in treatment of depression. Too high a dose, which is very common with the antipsychotics in agitation for dementia. Adverse drug reactions, which are very common in all of these situations, or confusion about the instructions for taking the drug. Adverse drug interactions from co-administered drugs are virtually certain to occur once a person gets up to 9 or 10 drugs, and that's many of our patients. Now, the last thing I'm going to talk about here is I don't want to impose on your time for your meeting, but I do want to just say a few words about diversity, which is an issue in everywhere, but in Delaware, we have a diverse population and a healthcare disparity. These are data which highlight the healthcare disparity between the white and Black population in Delaware. The number of white patients, older adults who report their health as good or excellent was 48.5%, significantly more than the number of Black patients, 29.2%, related to factors of access to care, healthcare, education, and many of the other things we've talked about here. Alzheimer's disease is a disorder that disproportionately affects the diverse populations in Delaware and in the United States. If you are Black and older, your likelihood of having Alzheimer's dementia is double, and Hispanic around the same rate. These estimates vary from study to study, but there's consensus that the rate for Black and Hispanic older adults is significantly higher than in the white older population, and especially as people get to the old stage of 85 plus. Also, late life depression disproportionately affects Hispanic and Black populations. In one very recent large study, 25,503 participants, older adults, the Hispanic participants and the Black participants scores on a PHQ-8, which is like the PHQ-9, it's a measure of depression, were higher. And they also had different symptoms, anhedonia, sadness, and psychomotor symptoms more than in the white participants. So recognizing depression and treating it aggressively is very, very important, and is facilitated by people getting healthcare follow-up and appropriate access. Now, suicide, strangely enough, peaks in a diverse group. American Indians and Alaskan Natives peak in their 20s, but that drops down. It's the non-Hispanic whites and especially males who are the high suicide risk population during later years. Late life alcohol use varies somewhat also between populations, and you can see that it's the elder white population that are abusing alcohol more or using alcohol more in this situation. Okay. Sorry about that. Now, finally, just a word about services for the aging population with dementia and these other conditions through Delaware, primarily through DHSS and DSAPID. The Division of Services for Aging and Adults with Physical Disabilities, through its Delaware Aging and Disability Resource Center, has a wonderful website with many links. And I mentioned there are a few that are dead ends, but many are active, good links that help individuals find personal care services, adult day services, emergency response systems, respite or in-home care, meal programs, or caregiver support. And this is a resource well worth exploring. Geriatric inpatient psychiatric care can be obtained a number of places in Delaware. Meadowood, Rockford Center both have geriatric dedicated units. Delaware Psychiatric Center does as well. Christiana Care provides services to older adults in its inpatient service. In all of these settings, one of the unfortunate problems is follow-up in the outpatient world. Finding geriatric skilled providers is difficult. ECT, which is so important as a last resort or most effective treatment for late life depression, is only available now at Christiana Care, as far as I know, in Delaware. And in terms of drug treatment facilities, Delaware does pretty well compared to the United States, especially in medically assisted treatment of substance use and methadone treatments. I will highlight that buprenorphine, where the United States and Delaware is relatively low in buprenorphine facilities, this is the preferred treatment for older adults because of drug effect associated with methadone. So to conclude, the kind of challenges that I see facing our state are that we need a more educated public about the health conditions that I've talked about, and access to healthcare and understanding what healthcare is needed. Reducing stigma is part of that. Educating providers, and especially primary care, where our older adults go and get their care. Expanding the workforce, I can't emphasize how important that is to improve access and to address the needs of our diverse population. And I can take some questions now if you like, or if I've overstayed my time here. Thank you for your attention.
Thank you, Dr. Ellison. I hope you all will join me in thanking Dr. Ellison for his presentation. We've got plenty of time for questions. If folks have that, they can drop them in the chat. Sharon will help facilitate that. But I do want to say I see some of our partners here from the prevention space, and I know a lot of you all are leaning into, I'm thinking of Dr. Ellison's presentation around polysubstances in the home and what risk that is for young people who may be looking to experiment with drugs or medicines and the opportunities there. We have some folks from SN4C who are doing a lot with doTERRA bags and those types of things for the proper disposal of medication, unwanted medication. And then that piece around early education, we have some from a partner here from the Department of Education, and how important that is to close those gaps around disparities in education, what impact that has on later life. So I thought your presentation was really, really great, Dr. Ellison. Thank you so much.
MJ, this is Sean. I just wonder if I can voice a question just to raise the issue. One of the things talked about is improving accessibility. And one of the gaps I see constantly is this is the same population that has to confront multiple doctors for cardiovascular disease, for internal medicine, stuff like that. Seems one of the things that are lacking is helping them to navigate these systems. And we don't really have a good system of health navigators, either through senior centers or AARP. So I just don't know if that's something else in terms of community providers that people are seeing.
I think that's an excellent point. Navigating the complex healthcare system is especially difficult for people who have mild or more severe cognitive difficulties. So we run into this all the time. For a person with dementia, sometimes a care manager, a geriatric care manager, can serve that function, but that's an expense that I think should be addressed by the healthcare system and by insurance rather than out-of-pocket expense. So I think our healthcare system really could do better with patient navigation help.
Thank you, Dr. Ellison, for just the wealth of information you covered in a very brief amount of time. We do have a number of questions that are coming up in the chat. The first question from Dr. James is, what percentage of Alzheimer's disease is genetic?
This is a question that we're often asked in a memory clinic setting or primary care. Many people who have Alzheimer's disease in their family are worried that they're going to develop it, especially if they're aging and they see some forgetfulness developing, like can't recall somebody's name or a date or a conversation. But the good news here is that Alzheimer's is largely not heritable. There are certain genetic risk factors, but it's considered a polygenic inheritance. You have to have lots of risk factors to really increase your risk, unless your family is unfortunate enough to have the autosomal dominant mutations of genes, which lead to very heritable Alzheimer's dementia. And those pedigrees, those kinds of families are being studied very actively to find ways of identifying who's at high risk and intervening very early. But I would summarize that the answer to that question by saying that if your relative was older than 60 when they developed the onset of Alzheimer's dementia, your risk is relatively less heritable, and you should worry more about lifestyle factors like we talked about as prevention.
Thank you. The next question comes from Bill Lynch, and he wants to know how should the elderly best be educated on the negative impact of cannabis on their health and medication interactions?
Well, thanks for bringing that up. You'll notice that I didn't really say anything about cannabis in this presentation because that's a kind of a controversial area, and legalization, has made cannabis available in many places for younger and older adults, both in multiple forms. So a lot of older adults use cannabis in edible or smokable or other kinds of forms. The risk factors for cannabis are significant as for alcohol and prescribed medications. And I think if an older adult knows the risks and has discussed that with their healthcare provider and has discussed the interactions with medicines they're taking, it can be a relatively safe medication to add to their other medications.
Thank you. This question comes from Karen McLaughlin. Are there any initiatives regarding affordable housing specifically for elderly population in Delaware, especially housing that offers affordable wraparound services?
I think I'm the wrong person for that question. It's sort of a little out of my wheelhouse.
Thank you. And I think that's all that we have in the chat right now, but I
I
believe
have one other question. Yeah.
Yes.
So Dr. Ellison, someone submitted a question. They asked about the continued impact of the lack of depression screening and diagnosis in geriatric populations in Delaware, including misdiagnosis. And what are we doing to support older adults in these circumstances?
Well, one of the great advances has been the Medicare annual wellness visit, which mandates that any senior once a year needs to be screened for depression. So if we can adhere to that and follow up with people who screen positively for the possibility of depression, we would be doing a lot better. Then integrative or collaborative care, which embeds a behavioral health consultant in a primary care practice, is also very good. Outside of that, educating the primary care community about advances in the treatment of late life depression and increasing Delaware's workforce of geriatric psychiatrists would be important longer term steps.
So Dr. Ellison, I have a question, and this is a little bit about workforce. I am grateful whenever I go into a clinician's office and they're asking questions about depression or mental health in general. What I've observed in a number of situations is that they're not very comfortable with asking these questions and the follow-up. I mean, you know, I'm not sure that they are really prepared to go further sometimes when questions might be answered in a way that they're not anticipating. I think in addition to just putting policies and procedures in place, I think there needs to be more, you know, a much more in-depth comfort level, let's say, with being able to talk about behavioral health in this way and being able to actually, you know, really make it integrated and not on a more surface level.
Well, I think this is a very important comment because it highlights that there are certain taboo areas that we don't feel as comfortable talking about. Death, suicide, depression, sex, money, abuse. All of these things are topics that some providers don't feel as comfortable bringing up with older adults. And for example, frankly, talking about death is something that is very comfortable for many older adults who think about it in a way that younger adults don't, because it's not as imminent. But as one gets older, the specter of death becomes more of a reality and planning for it becomes more important. Only about 30% of the population have filled out advance directives, for example, which gives you a little window into the idea of how we don't like to think even for ourselves about these topics. But when we start talking about, you know, things like abuse, suicide, sexuality, all important issues for our older population, we have to cross out of our comfort zone. And there are certainly ways that providers could be educated and exposed to more information to reduce the stigma or discomfort, but that would require quite a initiative.
Thank you. I think Karen has a question.
Yes.
Karen Coughlin?
Yeah, I wanted to follow up on my comment about the housing and piggyback on what Sharon is saying. So agreed, housing is not necessarily your physician's problem, but if you are an older individual and you have multiple health issues and potentially depression, housing plays a key part. And particularly if you're a transplant for another state that we're seeing a lot of, or, you know, you've just out survived your family or whatever the reasoning, you may be alone in this state and maybe struggling with housing and other services that are needed so that you can get this holistic care. So it becomes your physician's problem because, you know, you can hand out all the medication you want and you can see people and test them for 1,000 things. But if they go home and they're isolated, or if they have no home to go to, or, you know, a myriad of other scenarios that are possible. And with the housing crisis in Delaware, these are becoming more and more prevalent. This population does, you know, if they have any income at all, it's fixed. So they can't respond to this crisis of inflation and everything the way others may be able to. And that's why I bring up housing in relation to healthcare.
And thank you. I'm not disagreeing with you at all. I think that it's very clear that housing is a whole part of the problem, and that a person can be, you may be aware that the elder component of homeless adults in the United States is the fastest growing group of homeless, many from medical bankruptcy. So that the medical healthcare system and the homeless or housing problem are very intimately related in that way, as well as others. Delaware has a variety of options, and I'm just not educated enough to really talk about that. My experience personally is somewhat limited to trying to help a few of my patients and to help a relative who is seeking nursing home care in the state of Delaware. And I found some of the facilities to be pretty responsive and helpful, but finding low, you know, like Medicaid beds in the assisted living world, for example, or getting people into nursing homes, or finding low-cost senior housing is difficult in Delaware as everywhere in the United States, but definitely an issue. Thanks for highlighting it.
Folks, do we have other questions, other thoughts?
I just want to kind of piggyback on that last discussion, but also the broader discussion of navigation and wraparound services. There is an initiative, the Delaware Community Legal Aid is involved in projects throughout the state with different healthcare facilities, medico-legal partnerships that have been proven as models of integrated care that discuss, you know, the importance of home environment on health, behavioral health, et cetera. And I think throughout our discussion today, we've talked about the navigation challenges that exist for older individuals, as well as for everyone in the healthcare system. And I guess this is a question that I will just throw out to our entire SEOW network and say, you know, how is it, what could we do to, you know, promote at a policy level navigation services and wraparound services, because intuitively we know that if these things are in place, they're going to improve the health outcomes of individuals. But what is it that we can do to sort of support those kinds of policies? I mean, you know, it's like a research challenge. How do you prove this? Or what is there evidence, or could there be evidence to support this so that navigation services could be covered by Medicare and other kinds of insurance? This is just the thought that bubbles up every now and then, because clearly if you have people having medication interactions that cause additional problems or untreated conditions, that's got to be more costly than having someone help you navigate a system and making sure that your care is coordinated. That's just a comment, but if anyone has thoughts about that, I think it would be a tremendous area that we could work on to promote better policy.
Well, in terms of this, Sean, again, in terms of advocacy, you're right in my alley here. One of the things is, and this is not the only delivery mechanism, but we have a lot of senior centers around the state. Senior centers receive grant and aid. Okay, and many of us in the community have been fighting all along to have outcomes-oriented grant and aid. But you know, if that was a line item, you know, towards there, I mean, I would love it if AARP would take a lead too, but they haven't. But we need to find those that maybe touch senior populations. And again, that's not going to solve everything, but we have a great network of senior programs, as well as aging in place programs, but health navigation is paramount.
Thank you for that comment, Jody, about the risk to developing gambling problems, which leads to other problems, health, financial, homelessness, depression, and hopelessness. Something that really resonated with me, Dr. Ellison, that you mentioned was around caregiver burden. As someone who has experience in the behavioral health space with youth with challenges, and you see the need for respite care, especially for young adults that may have IDD challenges and what that, the impact of that in families. I thought it was really powerful that you brought that up around the impact of our aging population, not just on the individuals themselves, but the importance of that in families and social supports, and how, as we support our elders, we also need to support the people who are supporting our elders. So thank you for raising that. And I acknowledge, Jody, your comment about it's not just a matter of aging. There are these other ripple effects as well.
Dr. Ellison, it's Bill Lynch. Thank you for your presentation from a fellow Jeffersonian. I appreciate your presentation. It was great. And also with Carol Lippa, who we deal with all the time with some of our family members. So I know your connection there. But I want to respond also to Sharon's question about navigating the healthcare system. So with Jefferson and actually other healthcare systems now, they do have nurse navigators. It's actually a great resource for senior citizens to tap into to be able to help them navigate the system. There's also the opportunity through your insurance, depending upon who your insurance provider is, they will have people that will assist you in navigating the system. You can actually call and ask those insurance places for help. And then with regards to seniors navigating that, all the time, I can't tell you how many times I am quote unquote a family member of different friends of ours who are elderly, and that when you have someone who is in the healthcare system who can just be a friend of yours to help you navigate the system because they're familiar with the pitfalls and what's going to happen, as Dr. Elsie even mentioned, him helping someone to try to get into a nursing home situation as well. When you have someone who's a healthcare professional navigating that for you, we can get through roadblocks that people are unfamiliar with. We can help streamline that. When I call for my mother and my mother-in-law's care, that I'm a clinical pharmacist at Jefferson, you get a different reaction than if you're someone who's just calling on their behalf because you're someone's daughter. I mean, all of those individuals can help out with that. So to actually anyone you know who is a healthcare professional, to befriend them, and especially even if it's someone who's elderly and has younger children or siblings or whatever who can actually have those friends work the system for you, it definitely streamlines it much better. And we understand that. And having two elderly parents on both sides of our family who are above 85, like Dr. Ellison was talking about, we're dealing with those situations every day. So we're the health navigator, we're the medical proxy person for both of them. So I understand that, but to truly ask anyone that you know who's a younger healthcare professional to be able to do that. And with something happens to me and we're not around, I have two children who are clinical pharmacists that they can default to her in their late 20s and early 30s to help navigate the system as well. And they do as well for friends of theirs, even if they're younger. If you just aren't in that world, it's much harder to navigate it than if you are. So they're just some suggestions based on Sharon's questions she put forth to everyone. And thank you, Dr. Ellison, again for a great presentation. Thoroughly enjoyed it.
Yeah, my pleasure.
Thanks, Bill.
I want to
Cheryl,
acknowledge Dr. Ackerman. Yeah.
go ahead, Cheryl.
So yes, also thank you very much. This question is, I guess, for Dr. Ellison, but for others who work in the elderly sphere. I've been working on a project that deals with pediatric psychiatry and collaborative care practices and telehealth, trying to help increase the capacity of pediatric providers in dealing with behavioral health in their practices, because there is a shortage of behavioral health, of psychiatrists in particular, in the state of Delaware. So it made me wonder whether similar approaches would work with a geriatric population. So to have a consulting psychiatrist, to have a telehealth, a place you can call at any time, and within a day or whatever, you get a call back from someone who can consult with the provider who has given some screens, doesn't know what to do exactly, isn't completely comfortable, but would like some assistance in caring for one of their patients. I mean, what would, and I guess in addition to that, we're in the process of trying to develop a proposal for a grant And initially we were just going to be expanding on the pediatric, and then we realized that actually they did specify pediatrics for this particular grant. So there is the possibility of expanding to other groups. So I'm interested in people's thoughts on whether this is a good idea, if there are existing models like this that we might be able to build on and cite as like, hey, this is already, you know, something.
Yeah, have you, I assume you're talking about the DC PAP?
That's
project?
correct.
Yeah, that's a wonderful model program that's been tried in other states as well,
Mhm.
and has greatly increased the expertise of pediatricians in treating behavioral disorders in young adults and children as a result of consultation availability from
Right.
experts. It's also been recommended for older adults, and I would strongly advocate for that. I think it's an ideal population. And there's the same problem of shortage of experts. In fact, per capita among the elder population versus the child population, there's a greater shortage of geriatric specialists. One model that's been tried already is the ECHO system, where there are remote conferences and experts. And one of the people who I know who's done this in New York with great success is Dr. E.J. Santos, who was just elected, I think, president of the AAGP. Very collaborative geriatric psychiatrist and a good resource for you to reach out to. And then I know Dr. Borer, who you must be working with regularly, probably would have interest in extending this discussion, and anything the Psychiatric Society of Delaware can do to facilitate, we would be at your service.
Thank you very much. I appreciate that.
I think one of the other things to address with your question also is the significant difficulties with telemedicine if, one, the practitioner is not licensed in that state, and two, if the patient does not reside or have an address in that state. This is a major, major issue right now, up to including there's a test case out of New Jersey where a specialist who is in the Boston area providing significant high-level pediatric care to a patient in New Jersey was denied the access and denied payment because of the fact that that person did not live in Massachusetts. It's actually a test case that's going through the courts now because it's so difficult with telemedicine. And one of the major ones to stress, as Dr. Ellison did and yourself, Cheryl, is the fact that due to these shortages, it's actually a way to actually address them, to have practitioners outside of that state be able to take care of patients, but it's posing huge difficulty with regards to it actually being done.
So Dr. Ellison, if we still have you for a few more minutes, I just wanted to ask about something we really didn't discuss at all today, but something that's kind of near and dear to my heart, and that is, talk therapy as a method of treatment for older individuals. In addition to the medications and the assessments for depression and such. In my experience, in a former life, I worked in community mental health, and I gravitated towards older clients. And I think there's a myth that they don't want to have talk therapy, that they don't necessarily benefit from it. And I did not find this to be the case. So in addition to having just first we have tiers, we need more geriatricians, we need navigators, we need people with expertise in geriatric psychiatry, and we need people comfortable talking in the primary care setting. But we also need therapists that are able to work with this population as well. Are you finding, and you've been all over Delaware for years now, are there clinicians out there that are either specializing in this area or that just included as part of their general practice? I mean, are we in trouble in that regard as well?
Well, I'm so glad you brought this up, because my experience, like yours, is that older adults are fantastic psychotherapy patients as long as they can make it to an appointment or manage the telehealth equipment, or their hearing is good enough to participate with the telehealth, or they have assistive devices, or they're cognitively intact enough to carry forward information from one session to another. And that's the majority of older patients are suitable candidates. Many older adults go to their primary care with a problem of anxiety or depression or sleep difficulty, and they come away with a prescription because that's what's accessible in that setting more than psychotherapy. But many of them would prefer talk therapy. We know that talk therapy is a better treatment for insomnia. It's a good treatment for depression. It's as good as medicine for anxiety disorders. And it even plays a role for people with mild cognitive impairment. So psychotherapy is very important. There are issues with training, access to therapists, and reimbursement. Those are the obstacles that prevent older adults from getting psychotherapy. But there are at least 4 evidence-based approaches. There's cognitive behavior therapy, interpersonal therapy, brief psychodynamic therapy, engage therapy, problem-solving therapy. These are all evidence-based approaches to working with older adults.
Thank you.
Thanks for bringing that up.
Are there any other questions for Dr. Ellison? Well, again, this was a tremendous wealth of information, and we are very appreciative of your time and all of particularly the population perspective that you brought today, and the specifics about Delaware as well as national whenever possible. We know that data is sometimes hard to come by for this population, so thank you for putting together just a wonderful umbrella of information. MJ?
Yes, Dr. Ellison, thanks again. We really appreciate you. I know this has been a really rich conversation, a really rich discussion. I don't think you've heard the last of us, so that's what happens when you do a good job, Dr. Ellison. But I want to encourage others to reach out and connect with us if you have questions about this topic. Like I said, we will be sending out information after the meeting. With our last few minutes that we have here, we do want to invite any other if you have events coming up or resources that you wanted to share. I know our friends at the Gambling Counseling have some really great information that they're going to be sharing with us. And I see you, Brandy. Go ahead.
Good morning, everyone. Thanks for the presentation. It was absolutely wonderful. And living in Sussex County, I do see a lot of that in my personal life. I do want to share on behalf of SN4C that we were just able to present at CADCA's National Forum on Prevention plus Law Enforcement, a roadmap to positive outcomes in your community. And in that presentation, we highlighted the DEA Take Back event. And if you are unfamiliar with the DEA Take Back event, it is happening twice a year. And the next one is Saturday, April 27th from 10 to 2. You are able to dispose of all of your unused, unwanted, expired medications. At all of these events, there is a zip code locator. So if you're interested for maybe other family members in different states, you can visit the DEA website, type in their zip code, and pick your area. So maybe up to 20 miles and see all of the locations that are available for disposal that day. If you do have other family in Delaware that is unable to participate in the event on the 27th, I want to remind everybody of the drop boxes that are available every single day, except I do always encourage everybody to call before they go, because my luck, they'd be closed for renovation that day. But you can find that on the Help Us Here DE website. And last but not least, MJ, I did hear your shout out earlier about the Terra disposal bags. We do still have them. We do trainings across the state. It is an at-home disposal pouch to dispose of those medications. So if anybody's ever interested, please reach out to our group. We can hook you up with some Terra bags to distribute where needed. But thank you again. Hope everybody is doing well.
Thank you, Brandy. Dr. Cuffey has also put some information in the chat around the SHIP Coalition meeting, which is in person at the Bear Library, the Partnership for Healthy Communities, Public Health Professional Mix and Mingle, the Equity Awareness event, which is coming up in April. I hope you all, as a public health nerd myself, I hope that you all attend that. It is at the Chase Center. Yeah, Chase Center downtown. So really appreciate that information. If you haven't received it, we can send that out as well. Other events, other things going on here in Delaware you want to share, folks? No? Sharon, you wanna bring us home, madam? The opioid response conference at the Chase Center in May, towards the end of May.
And MJ, just the Attack Addiction 5K fundraiser is
Oh,
Saturday
yes, you
2nd
did.
at 9 o'clock. So if people want to sign up for that, that'd be great. And also Attack Addiction has opened up our resource center now in the Newark area. They're off of Route 4896. So if people are, that's open and staffed. So if people want to gain access to that, that's also available for as a resource in Delaware as well.
Delaware is doing a lot, folks. What else do we have? Anything else? Any other events or resources?
We have a cultural community symposium on problem gambling and mental health on March 13th from 10 a.m. to 2 p.m. And it's at the Delaware State Troopers Association Hall at 6349 North DuPont Highway in Cheswell, Delaware.
Thank you for sharing that.
Jody,
And folks, go ahead.
I'm sorry, excuse me. I was just going to say, if folks can pop their information in the chat, then everybody can have, we can have it in the transcript. Or if you don't have it now and you want to send it to us, we can see that we send that out when we send out notification about meeting slides. Is that right? Right, MJ? Right.
Yes, ma'am.
Great.
Almost forgot how to spell your last name there. So feel free to send us those flyers and events, and we will make sure they get out with all of the meeting materials. Thank you for the SOAR conference. The SOAR conference is really informative.
Okay. We have the Building Bridges Conference being mentioned. Jonathan Rhodes popped that information in the chat, and that is April 29th and 30th. And that's at the Doubletree in Wilmington. And Kids Count in Delaware Focus book release will be held on May 1st, 10 to 11. It's a virtual event.
I love it.
And thank you, Hannah, for putting your contact information in the chat box. We're delighted to have you here today. And Bill, thank you for popping that in the chat.
Sharon, it sounds like people better enjoy this snowy day now because it's going to be a busy time in Delaware in March,
right.
April, and May. We're getting some work done,
Right.
folks. I love it.
Right. Well,
Also free and Sharon, just to stress the need for all of your data. I don't know if anyone saw the recent New England Journal of Medicine article that was published on January 11th, stating that now in 14 to 18-year-olds, their substance use attempts is going tremendously down. However, their death rate is going tremendously up. And those numbers were actually for 14 to 18-year-olds. We lose 22 adolescents every week from an overdose in the United States. They're the new numbers. So it just stresses the importance of the work that you're doing with your group, MJ and Sharon and others, because that information is get out about how significant it is in Delaware, but it's definitely becoming a more increasing national problem, even though we focused on geriatrics today. And they're actually dying at an older rate as well. There's actually data from California showing that those individuals who are using cannabis and having problems are increasing tremendously. It was out of the entire state of California, up to including that the ones who are using and having these problems are the ones we least expect. So what I mean by that, it's our healthiest seniors who are using marijuana. Those who had higher levels of comorbidities, 3 and higher, had the second highest increase in cannabis hospitalizations. The oldest group was those who had no comorbidities, who were over 65 years of age coming to hospitals in California. So it's significant with regards to information. I just throw that out there for our audience to be able to share that today. So thanks again for having these forums. They're tremendous and we appreciate it. And great speaker today as well. So thanks again.
thank you, Bill. If you can shoot us that citation, that would be great.
All right, folks, if there is nothing else, no other resources, or if you, after the meeting's over, you think about it, you want to send it to us, both my email and Sharon's email is in the chat. Please feel free to send it to us. We are so appreciative of your time this morning, and we thank you for coming, and be on the lookout for more resources, as Bill Lynch mentioned.
Thank you, everyone. Have a great day. Stay warm, be safe. And our next semi-annual meeting will be in the summer. I believe we'll be doing a hybrid, probably in person and virtual, because we know we like to gather. but we will send more information out about that. In the meanwhile, this is your SEOW. If you have ideas, if you have questions, if you have data needs, please do send us emails, and we are always looking for your input. Thank you so much.
Thank you, and have a great day, everyone.